Good afternoon, good morning, good evening, wherever you might be in the world. My name is Ravi Mamtani. I am a professor in population health and in medicine at Weill Cornell, and also the vice dean of Institute for Population Health at Weill Cornell Medicine in Qatar. I extend a warm welcome to all the participants for yet another exciting seminar discussion in our population health and well-being series. A reminder that our series objectives include one, discuss contemporary and critical topics relevant to healthcare, medicine, population health, examine evidence-based practices germane to public health and patient care, and finally, describe opportunities and challenges in the evolving phase of healthcare and population health. A couple of housekeeping notes. Your cameras and microphones are turned off. Please use the Q&A feature to type any questions and or comments that you might have. And again, as a reminder that the questions will be addressed toward the end of the session. This activity is approved by the U.S. Accreditation Council for Continuing Medical Education, as well as the Continuing Medical Education Department and CPD of the Department of Healthcare in the state of Qatar. Just an important notice, and as a reminder, please update your profile on Cloud CME. And the deadline to update your profile, in fact, is today, which is April the 16th. Insofar as evaluation and certificates are concerned, the post-activity evaluation will be available in your Cloud CME. Healthcare practitioners licensed in Qatar will only receive their credits once the Qatar ID and MOPH license has been provided. You will receive an email notification once the evaluation is available in your Cloud CME account. And finally, your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So now on to our exciting topic. And the topic's title today is Travelers' Health, Risks, Recommendations, and High Altitude Considerations. And we have absolutely an outstanding expert in Dr. Rajiv Narula to present that topic to us. Just a brief biographical sketch on Dr. Narula. He completed his undergraduate studies from Boston University and then went on to complete his medical education program at St. George's University School of Medicine. Subsequently, he completed his residency in family medicine at St. Mary's Hospital in New Jersey. And having learned various things about preventive medicine, primary care, he then went on to focus on travelers' health. And indeed, in 1996, he founded the International Travelers Health Consultants. He renders travelers' health services to a wide range of clients, including major corporations, their employees, diplomats, leisure travelers, and anyone who is seeking advice on travelers' health. Board certified in family medicine, travelers' health, and U.S. Department of Transportation medical examiners, he's an outstanding clinician with excellent skills. I know this personally because I've known Rajiv for quite a few years. His current positions, among many others, the ones that deserve special mention include assistant professor at New York Medical College, Valhalla, New York, medical director for occupational health, Hudson Hospital, and medical director, as I said earlier, of International Health Consultants. So with that, I invite Dr. Narula. Narula, we're grateful to you for taking the time out of your busy schedule to be with us this morning for you in New York, for us late afternoon, early evening in Qatar, and for many others around the world, maybe evening, night, or morning. But thank you so much, and we appreciate your graciousness to spend time with us. Thank you. Over to you, Rajiv.
Thank you, Dr. Mamtani. I have known Dr. Mamtani for several years. and I have always, and he was one of my early mentors when I was exploring travel medicine. I've tried to come up with an interesting topic for you all today. Try to move the slides. I have no conflicts of interest, financial or non-financial. I will not be discussing any unlabeled or unapproved use of drugs or products. It's just love of travel and medicine. So today, the objectives are going to be, we're going to talk about travel medicine and how you would see a patient and tell them what to do so they're safe on their trips. We're going to look at international risks on a macro level in the same kind of way that when I see a patient, I'll kind of mimic that. So it makes it easy, I think. And then the last part, we're going to talk about high altitude medicine. I was fortunate enough to climb Mount Kilimanjaro using travel medicine skills. So what is travel medicine? Travel medicine is a unique specialty that can be impacted by geopolitical and environmental issues. My experiences in family medicine, emergency medicine, and love of travel have helped me reach this point. Although the love was not enough, I had to spend a lot of time on self-study, went to lots of courses, and immersed myself in everything travel related. Beyond that, I enjoy what I do, and I've been doing this for a long time now. Travel medicine is a distinct medical discipline that arose in response to the need for accurate, reliable, and up-to-date information on the health risks of travel. The pre-travel consultation is the bedrock of this effort and the best opportunity to educate the traveler about health risks at destination and how to mitigate them. The recommendations that are made at the consultation needs to reach a fine balance between destination risks, recommended and or required vaccines, cost analysis, because in the US, it's not a covered service, preconceptions that the patient may come in with, and they have a lot, recommendations from their friends and families, which also play a role, and it's usually not that helpful. As all these go into the decision-making process, this could easily make the consultation several hours long, but we only have between 15 and 30 minutes with each patient, so you have to be organized in your approach. The next few slides will just go over some travel statistics. The most popular destinations in the world are Europe, followed by Asia Pacific region, Americas, Africa, and Middle East. There is a significant increase in Asia Pacific over the last few years. So why do we travel? There are many reasons why we travel. I have listed some of them here. We're going to be speaking about adventures travel later on. And the ones that I have highlighted in red are usually the high-risk travelers who, due to their misconceptions on health issues, may miss out on some of the preventative recommendations. This slide shows you that around 2019, there were 1.4 billion travelers in the world, and that dropped drastically during the COVID pandemic, and it's gradually rising again. This basically shows you that in the tourist industry, there are about 320 million workers right now, and it'll go up to around 430 million over the next few years. 10% of the world's GDP is travel related. In the US, the CDC has a big role in travel health with a great online section on travel medicine. They also played a big role during the pandemic to provide guidance to a confused country and world. Travel diseases have been around as long as man has been venturing to explore the world for various reasons, some good and some bad. There is a list up here, and as you can see, if we pick between the 15th and 16th centuries, the America saw introduction of smallpox, syphilis, and measles with the new explorers of the world. I mean, the world was here, but it was new to them. And then recently we have some situations in Gaza and the Ukraine where due to the war, you're seeing spread of diseases, psychological issues, and the like. So at a pre-travel consultation, the patient will provide information which is important so you can evaluate them. So the basics: age, sex, medical history, medications, allergies, immunization history, and special health needs. Further along, we need to ask them about their trip, about where they're going, how long are they going for, what's the mode of transportation, the purpose of that trip, planned activities, quality of accommodations, financial budgets, insurance issues, and healthcare standards at where they'll be going. Once we have this information, then we can do a risk assessment and we can advise to reduce exposure to certain health risks. We may recommend some vaccinations, chemoprophylaxis for malaria, for instance, advice for self-treatment, and the use of travel kits and supplies. Because once destination-specific risks have been assessed, communicate them clearly to the traveler. Communicating risk is one of the most challenging aspects of a pre-travel consultation because travelers' perception of and tolerance for risk can vary widely. As mentioned in an earlier slide, reaching a fine balance with recommendations is a crucial aspect of this. This is a patient I had maybe a month ago. It was a middle-aged woman who was traveling to Latin America, and she was going to fly from Miami, fly to Quito, which is at an altitude of 9,500 feet. And then she was going to go into the rainforest and then cross over into Lima, which is in Peru. And then from there, she was going to go up to Cusco. So when I'd seen her, I'd explained everything to her. And then after she left, I realized how complicated her situation was. So I made a little sketch for her and I sent it to her. She was happy. And actually, she walked into the office yesterday and she was confused about some of the directions. So basically, when you're in Miami and you are flying to a high altitude area, because a flight is a few hours long, to prevent altitude sickness, even on a flight, the recommendation is you do 1,000 feet a day. And here we're going to go to 9,000 feet within a few hours. So the recommendation is you would start a medication called Diamox or acetazolamide. You would start this a day before your trip, continue it twice a day, and you would continue it for 3 days on your maximum altitude. So once she's at Quito, she was going to go into the rainforest. So then we had to have a sort of malaria pill a day before she went into the rainforest. And she would continue this while she's in the rainforest and for a week after that. So now she's made it over into Lima, but she's crossing a country. Both countries have yellow fever. So she was required to have a yellow fever vaccine to make that journey. So once you're in Lima, then she had to restart the Diamox because of her flight to Cusco. And so these are things that she came in yesterday and I had to just explain to her a few other things. But she was very happy at the end. So when you do a pre-travel evaluation, you as a provider needs to remember a lot of things, and we can't forget because we all have busy schedules. And then we also want to make sure the patient will get the most of the visit and remember what you've said to them. So what I have done is I have divided the risks into food and water risks, and I go over all the risks for them. And then the next risk is mosquitoes, followed by people-associated risks. And then you have rabies, usually from dogs, rarely from monkeys. And then you can also talk about air evacuation insurance. And then you always need to remind your patients, don't park your brain at the airport. You need to take it along. Because a lot of people, when they go on a trip, they seem to forget normal rules and they just take risk activities sometimes. So in the food and water section, I'll just go over the stuff I go over with patients. So the first disease is hepatitis A, which is a common viral illness. There is a very good vaccine for this, and I recommend this for the traveler. When you have the first dose of hepatitis A, you're usually protected for this trip, and then you would get a booster 6 months to a year later on. And then the protection is 15 to 20 years. Typhoid is your next illness, food and water based again. High risks are in India, Pakistan, Afghanistan, and West Africa. There is 2 vaccines available. One is an oral formulation, which needs a week to take the pills, and you can't be on antibiotics at the same time. And the second option is a vaccine you would get, which is an injection, and it lasts for 2 years. Hepatitis C is also a food and water illness, although we do not have a vaccine in the Western world. There is a vaccine for hepatitis C in China and Pakistan. Hepatitis C can be severe in pregnant women and people with problems with their immune system. So you have to be careful about eating and drinking. Everything has to be well cooked. The water has to be safe, all those things. Polio is another food and water illness. We have the Sabin and the Salk vaccines. Most people have these vaccines. When you go to potential risk areas like in Africa and parts of Asia, you may want to get a booster as an adult, which will last you for life. Cholera is our last food and water problem that has a vaccine. Cholera is due to a toxin, so the onset is usually sudden. There is a vaccine available, which usually lasts between 3 and 6 months. Currently, they've been having a problem with cholera in Southern Africa, where they've had thousands of cases and mortalities. There was a ship that was circling Madagascar that had some patients with cholera, and they were not letting them onto land. Last one is traveler's diarrhea, which you do not have a vaccine for. It is caused by eating the wrong food, drinking water, etc. It goes by many names, depends where you are. Delhi Belly is one of them, Rangoon Runs, Montezuma's Revenge, and Hong Kong Dog. Hong Kong Dog was used in the medical journals, in the Philadelphia Medical Journal in 1899. So I usually provide my patients with an antibiotic, azithromycin, which works really well for this. Schistosomiasis is also a water illness, usually found in fresh water if someone's walking or swimming in it. So the recommendation is not to swim in freshwater lakes in parts of Africa, Latin America, and Southeast Asia. There was a study done years ago where they used DEET all over your body, and it did repel the cercaria for a little while. Now we're going to move into the people-to-people section, and this is how I usually see my patients, and I go system by system so that I don't forget and they hopefully learn some things too. So meningitis, the main meningitis regions that we are worried about is in the meningitis belt of Africa. Meningitis is usually a problem in the dry season, as the bacteria lives in your mucous membranes, and in the dry seasons, you may have cracked membranes and the bacteria will gain access, and then you can spread it by coughing and sneezing. Hepatitis B would be a people-to-people problem, usually, bodily fluids, medical attention, sex, those kind of things. So it is a good idea to have this vaccine for long-term travelers. COVID, which we have lived through for the last few years. caused a lot of turmoil in the world, politically and medically. We are hopefully past that now. The flu vaccine is usually recommended for most of the adults in the US and also for young children. It is a good vaccine to consider when you're going to be flying because of all the people on a plane and trains and ships and all those things. So that's a good idea to have updated every year. So now we're going to move into the mosquito section. Mosquitoes whose only purpose seems to make human life more complicated. Malaria transmission occurs in tropical and subtropical areas. 40% of the world's populations live in endemic areas. In 2022, there were 249 million cases in the world. Out of that, mortality was around 619,000. Incubation periods usually 7 to 30 days. And we'll go over some of the specifics later on. This shows you sub-Saharan Africa. The risk in Africa for malaria is 1 in 50 without prophylaxis. So it is a very important idea to get your patients on this medication. For malaria, there's usually a 3-level protection. One is the anti-malarial medication. The second is using repellents, which I'll go over later on. And if your room is not air conditioned, then you should use a mosquito net. This just shows you some places in Latin America where they have malaria. This is a recent New England Journal article on a young man who went to West Africa without anti-malarial medications. And he came back with a fever and he was sick. He went to an urgent care center and they just treated him for like flu-like symptoms. They checked a flu test and they sent him home on prednisone. Obviously, he became sicker, and within a few days, he was in the hospital. He got admitted, and he had malaria. He did survive. So whenever someone comes back from a malarial area with a fever, you have to rule out malaria. That's the first thing. It can result in lawsuits and death. Dengue fever is the next mosquito we're going to talk about. Dengue fever is a daytime biting mosquito which can live indoors. There is no vaccine in the US for that. Currently, there is a big dengue fever problem in Latin America, and they are using a Japanese dengue fever vaccine, which has, I think, an efficacy of around 60%. Next one is chikungunya fever. Dengue fever, chikungunya fever, Zika virus, and yellow fever are caused by the same mosquito. And if you look at this, the mosquito has black and white leg markings. It's an Aedes aegypti mosquito. And the main protection with these ones is you got to use repellents. Chikungunya is, it's getting Lyme disease-like symptoms caused by a mosquito. There is a new vaccine for chikungunya, which got approved in the US over the last few weeks. Zika virus, like I mentioned, the same kind of mosquito with the black and white leg markings. There is no vaccine for Zika. And the next slides will show you some of the repellents that I was mentioning. DEET is used on your sun-exposed skin. The percentage of DEET will tell you how long it lasts, but not how strong it is. So the CDC recommends you use no more than 30% DEET. There are some products that have a slow release formula, so you don't use it as often. And then there's a spray called permethrin, which you're going to spray your clothing with before you leave. You can also spray the surfaces on when you reach your destination, because a lot of these mosquitoes live indoors. Some of the other products here, this is a UV pen, which is used to sterilize water within 45 seconds. And each of these gadgets will last you between 3 and 5 years, and it's a very useful thing to have with you. This is a skin emollient that we had used on our feet when we were hiking at Kilimanjaro, and it really helped because you didn't get any blisters and had no problems walking. Next mosquito we will talk about is Japanese encephalitis. This is an evening biting mosquito. It's usually found in Southeast Asia. It goes from Asia into the Western Pacific. There is a good vaccine available for this. It's a 2-dose vaccine, and you get protected for a year. If you do contract Japanese encephalitis, 1/3 of people recover fully, 1/3 of people have neurological symptoms, and 1/3 of people will recover. So it is important to get this vaccine if you go into the risk area in the risk season, which is usually in the summer times. Yellow fever is a problem in Africa and in Latin America. There is a good vaccine available for this, which provides you lifetime protection. These are countries in South America. So the patient I had last week, she flew into Ecuador, which is a yellow fever country, and then she crossed over into Peru, and that's why she had to have the yellow fever vaccine, and they usually check that at the border. Rabies is usually caused by dogs and monkeys. 99% of the time, it is a dog bite. High-risk travel would require 2 doses of a pre-travel vaccine, usually a week apart, and then you're protected for up to 3 years. If you get bitten, you need to get 2 more doses of the regular rabies on day 0, which is the day of the bite, and 3 days later. If you do not have the pre-travel rabies series, then it's a little bit more complicated, because when you get a bite, you have to assume the animal had rabies, because if you wait for symptoms, because once symptoms develop, it is usually fatal. So in the second case, you would have to get a rabies immunoglobulin vaccine, which is a very expensive vaccine. In the US, it costs $5,000, and that's followed by 4 rabies shots over 2 weeks. Death from unintentional injury like road traffic accidents, drowning, and homicide is a major risk to travelers. Injury likely accounts for the greatest risk of death attributable to travel and largely preventable. Road traffic accidents, 80% fatalities in lower to middle income countries where motorcycles are common, poor road conditions, poor road rules, seat belts, helmet use, drunk driving. All these issues have to be looked at. Studies done by Dr. Robert Stephan, who is known as the father of travel medicine. He not only initiated the first international conference on travel medicine, he founded ISTM, the International Society of Travel Medicine. He even named the entire field of medicine. So this study he did in 1987, out of 100,000 travelers who went to the developing world for a month, 50% will develop some sort of health problems during the course of that trip. 8% will see a doctor, 5% will be confined to bed. Out of those 100,000 again, 1.1 will not be able to work, 0.03% will be hospitalized, 0.05% will be air evacuated, and 1 out of 100,000 will die. So the most common health problems are usually GI related because of eating, drinking, all those things. Respiratory infections is next, followed by skin diseases, fever, and animal bites. This lists some other problems: malarial problems, influenza, dengue, TB, and hepatitis A among the travelers who go to high-risk areas. These are the odds of picking up some of these. Typhoid is 20 out of 100,000. Hepatitis B is 5 out of 100,000. HIV 2. 100,000, Japanese encephalitis, 0.1 out of 100,000, and meningococcal infection. So now the last section of this talk we'll talk about how we made it up to Kilimanjaro. I was involved in arranging this most amazing trip. This happened in August of 2017. Kilimanjaro is a mountain formed and sculpted and molded by the natural forces of volcanic fire and glacial ice. It was born about 750,000 years ago. If any of you have read the book, The Snows of Kilimanjaro, the story opens with a paragraph about Mount Kilimanjaro, the highest mountain in Africa, whose western summit is called in Maasai, the House of God. There we are told lies the frozen carcass of a leopard near the summit. No one knows why it's there at such an altitude. The question that comes up again is, why did we follow the leopard? In our case, we flew from New York. We flew to Amsterdam, where we spent a couple of days so we would get rid of our jet lag. And then we flew on to Kilimanjaro. It was an amazing flight where we crossed the Nile. It was just an amazing trip. This is when we had left the plane and we all waited to get into the lounge. And all these people are hikers, I think most of them would be. So some of the specs of Kilimanjaro is the highest mountain in Africa and the highest freestanding mountain in the world. The summit is Uhuru Peak at 19,341 feet. Everest Base Camp is below this. 35,000 people attempt the climb yearly. Success rate is 64%. Our success rate was 88%. So anyone traveling to high altitude is at risk of developing high altitude illness. Ascending to a high altitude may cause high altitude illness, which includes acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. High altitude illness is caused by low oxygen levels in the air and thus your blood. 8,000 feet or 2,500 meters is considered the usual threshold for high altitude illness. Some people are more sensitive and may have symptoms at lower levels. It's usually possible to prevent high altitude illness by ascending slowly. Pole, pole in Swahili was our daily anthem, and allowing your body to adjust. Serious complications can be avoided by watching for early symptoms and responding quickly. It is not possible to know if someone will become ill when traveling to high altitude. Being physically fit is good, but does not decrease the chances of high altitude illness. High risk people are ones who've had previous problems with high altitude, people who are overexerting themselves, rapidly ascending, and or who may have other medical problems with the respiratory system. So the most common and benign of the high altitude illnesses is acute mountain sickness. Usually 10% of hikers, I guess, at around 6,000 feet. And this goes up to 40% of hikers at 9,000 feet. Rapid rate of ascent increases risk. Usually if you're flying to high altitude places like Cusco, La Paz, or Lhasa, there's a 25 to 35% chance of having altitude sickness. There are no sex differences, no relationship to susceptibility to AMS and physical fitness, although you need to be physically fit to walk. So the symptoms that you may encounter, you may have a headache, bifrontal, worse when you bend over with the Valsalva maneuver, anorexia, nausea, vomiting, lassitude, weakness, feels like an alcohol hangover, irritability, leave me alone, sleepiness, deep inner chill. High altitude cerebral edema. Acute mountain sickness can progress to high altitude cerebral edema. 8% of those with AMS at 4,200 meters or 12,000 feet will develop high altitude cerebral edema, where you can get truncal ataxia and altered mental status. Untreated, this can progress and into stupor, coma, and even death. High altitude pulmonary edema. Usually you're short of breath, tired, weary, coughing. You may have cyanosis, central and peripheral, and it can develop within 1 to 2 hours, and even when you're descending. So with these kind of patients, someone has to be with them all the time. They can use an inhaler, give them oxygen, keep them warm. They can have an extra dose of acetazolamide or nifedipine. If you're unable to descend, you want to use a pressure bag, which we did not have. Death can occur, so you need to descend. It's possible to have all three at the same time: acute mountain sickness, pulmonary edema, and cerebral edema. So is Kilimanjaro dangerous? Kilimanjaro is probably one of the most dangerous things that you'll ever do. Every year, approximately 1,000 people are evacuated from the mountain and 10 deaths are reported, and these numbers may be higher. Evacuation is by a gurney where you get 4 to 6 porters who will take you down the mountain. I have a few slides on this. There is a helicopter evacuation available, which is from Mombasa, which is in Kenya, and it's not as cheap as you'd want it to be. So besides that, we had to also worry about infectious risks. So the infection risks in Tanzania include malaria, traveler's diarrhea, hepatitis A, typhoid, tsetse flies. And I have it in blue because when you went on the safari, they have these blue flags which have poison in them, which attracts the tsetse fly. So the one thing you want to do on a safari, if you go on a safari, you don't want to wear blue clothing or neon clothing because that attracts all these bugs. Yellow fever, which was a problem in Tanzania, but not anymore. Cholera, schistosomiasis, and dengue. So the non-infectious risks include altitude sickness, hypothermia, falls, sun-related injuries, fitness issues, foot problems, and logistical bathroom issues. So how do we prepare for this? We spent 1 year on this trip before we left. So we were all exercising at our different levels. We had to make sure we had the right kind of clothing for all kind of weather situations. We had to have other essential like skin care, hygiene issues, snacks, hydration, foot care, medication, and supplements. And all these had to fit into a bag that was 35 pounds. That's an error, which is carried by the porter. So this just explains some of the other things that we had to what we had to do and carry with us. It's a very intensive trip, but you want to plan ahead. So while we were planning this, we used to go hike in a place called Mount Beacon, which is in the Hudson Valley, which is about 1,600 feet. That's the highest we went. And then for our trip, we went up to Kilimanjaro. That was 19,000 feet. There was no comparison. So how do we plan this trip? We planned the trip. We picked the last night to be on a full moon night. So, because we'd be walking all night, and then we went back that way. So this is a little schematic I had made so I could just explain to our people what to do and when to start the pills. The next few slides will show you the medication packs I had. I had 3 kits. I kept 1 kit with me all the time, but essentials like medications and first aid supplies. The other 2 kits were in the duffel bag. I also carried a couple of books with me just in case, because your mind slows down on your hike. This MedX book is downloadable for free online. It is a great book to have with you. It tells you everything about travel and high altitude. And another really good book is by Dr. Eric Weiss on wilderness and travel medicine. This is just some of the kits I had with me. So we finally made it to the gate and we're off. These are our sleeping tents. That's the bathrooms over there, the tall buildings, the tall tents, sorry. This is just some more visuals of that. This is within my tent. We were given, this is our shower tub. We would be given half a gallon of water, which you would have to carry into your tent. And as you can see, the tents are very low, so I had spilled water, obviously. It was very cold in there, and you had to clean yourself, so that you'd feel fresh and ready for the next day. By the time you got ready to walk every day, you were exhausted because you had to do so many things. So what did I have? What kind of problems? I fell on the second day. I had a laceration on my forehead, my right knee, and a left hand laceration, which developed into an abscess, which I drained on one of the nights in my tent. I had no other symptoms of altitude sickness. I had some foot cramps. Beyond that, I had my supplements that I was taking, and you need to drink lots of water. That's my hand with the abscess drained. This is the mess tent. This is where we would dine and sit pre-hike for instructions. We would drink a choice of hot water. Sometimes we added honey to it. The food was okay. We would get millet porridge, which I had never had in my life. Eggs that were okay. But the thing that helped us a lot, we had some hot sauce with us. And you can put hot sauce on anything and you can eat it. So while we were walking, I was also treating other people, random people along the way. Like I was called to see a young lady who was around 20, crying in her tent. She was having her period. So I treated her with some non-steroidals and Lastita. This other lady I saw, she was looking green and pale and not too good. So I treated, I came up with this thing that worked really well. Combination of a PPI like Nexium or Prevacid to reduce the acid, Zofran for the nausea, and 2 Diamox tablets. I saw her a couple of days later. She was all happy. Treated a porter with a cough who was walking with us to get him a Z-Pack or azithromycin. We met these other Spanish males who were not taking any medications and were just doing randomly stupid acts on the hike up. They were doing headstands on the edge of the mountain. At the summit, one of them was asking for a ham sandwich. He was hallucinating, I think. Then when I came back, I had a patient who said she went up to Kilimanjaro. She did not take her medications and thinks she saw a Macy's at 15,000 feet. So it's a good idea to take your medications. These are medical issues along the way that we had. The green ones are the ones that could be altitude or other medical issues. So you have to also think about that. Like I said, is it AMS or it's not? So you have to, it's a trial and error almost. This is a little video they'll show you how we are walking among these volcanic boulders. This is at, I think, 12,000 feet, maybe higher, I don't know. But I had walked ahead of them, not that fast, but we did come ahead. And we did, as you can see, he was our leader. So he was walking in the front and walking slowly, setting the pace. Because one, he was going too fast. These are other friends of us on the trip who went.
Two peaks in 1 month.
This person had climbed, I think, Mount Everest the month before from the base camp. It was just an amazing.
Are you at the end of the line? Show me the end of the line.
So we were singing in Swahili at the end. Oxygen is only used for emergencies. You don't want to use it on an everyday basis because your body will not be able to get used to the high altitude. So it's just, like about 6 people used it at a one-time temporary relief on the trip. This just explains some more about the medications that we were using, which I had mentioned earlier. This is the road, the route that we had taken. We had taken the Makame road. So we hiked up 25 miles over 5 days, and then 2 days we came down. So we did altogether about 38 miles. This is an amazing site. We walked for hours. The solitude helps you sort out what's in your head and figure out what's important in your life. Getting in touch with nature is therapeutic in many levels. This is water purification by a team member. Some more walking. As you can tell, the porters have these bags, and the limit is 35 pounds, and it's all weighed before you start the excursion. This is Lava Tower at 15,000 feet. It's a 320-foot high volcanic mass. That's available for a side excursion. We were given the option, but then we decided against it in case something happened and we couldn't make it to the bigger mountain. This just shows you some of the tenting and getting ready for the walk. This next video is on This is on day 5, I think. We're walking up Barranco Wall, which is 800 feet above Barranco Valley, the most challenging section of the mountain. And just enjoy the visuals. And there's one point on this walk where the guide tells you, hug the rock, because it's a very narrow area. And if you look over, you think you're going to fall down. So you're facing the rock, and it's called the kissing rock, because everybody gives a rock a kiss. These videos were made by my daughter. She had on her GoPro, I think. You know, the camera that she had attached to herself. So you have to be focused on the walk. You got to forget everything else. You got to look at your feet and know where you're putting every foot, because if you don't, you're going to fall down. We were not carrying our backpacks here because the porters wanted us to focus on handling the mountain and not worry about our backpacks. So you do have to be, as you can tell, you have to have some physical strength. You got to pull yourself up. And this is the point, I think, where we're near that rock. These coverings at the lower leg are called gaiters, which is usually meant to protect your feet and also blocks any rocks or anything from going into your boots, because then you got to redo your boots and it takes so long to do anything there. So that's what we had. Okay, we'll go to the next slide now. This is the porters who are carrying somebody off the mountain. And you can tell it's not a smooth ride. There are a lot of boulders and rocks on the way. We saw a few people who got taken off the mountain while we were walking up. This person was using oxygen on the way up. I saw him using it. And then a few hours later, I see him being brought down the mountain. These are just some other photographs. This is our mess tent, you know, the night before we did our night hike. It was very cold. We just had no energy, always exhausted. This is Mount Mowenza, the second highest peak. Usually you'll see this at the end of your journey. It's just sitting around waiting to start the hike one morning. This is our last meal, the last supper, popcorn and warm water. This is us above the clouds at sunrise. It's an amazing sight after 5 long days and nights. The feeling that you have is sheer happiness and relief that you made it. We had sent 2 team members down the slope a few hours ago. We saw them a few hours later. They looked perfectly well when we saw them, because acute mountain illness resolution is rapid with descent and medication, and can lead them to ask why were they sent down as they feel well. This is just some others hiking on the top of the mountain. More beautiful pictures. One more short video on the top of the mountain. This is on the top of Kilimanjaro. You can see it's all volcanic rocks. Those are the snows of Kilimanjaro. I'm not sure if you see the leopard, but it's just an amazing place. And if any of you get motivated by this, you can always reach out to me and I can give you insight into how to make it a successful mission. Hakuna Matata. That means no worries.
Raj, look here for a minute.
Hey, buddy.
This is our group. We even got a diploma after we completed the climb. So what happened after we came back? We had all these medical issues amongst all of us, which lasted for a few weeks into a month, I think. Boredom was a big thing because it was just such an amazing journey. And shukriya for your time.
Thank you, Dr. Narula. That was absolutely superb, amazing. A lot of information in there with a lot of practical tips for people who may have an interest to travel abroad or even climb mountains. So thank you so much. Amazing discussion.
Thank you.
Just for your information, we have close to 900 people who were out there listening to you. So obviously your topic, obviously very attractive. And so we're grateful to you. In the Q&A and chat sections, I'll try and summarize if I can. Obviously, there are comments and there are questions. So a lot of compliments, a lot of thank you, amazing, and then so on and so forth. But also, I think a couple of challenging questions, Dr. Narula. You're the expert. So, so I want to begin with your remark about the TM specialty, travel medicine specialty. And I know based on my own experience, but you're certainly an expert, that there are not too many physicians who are really well qualified to be able to provide evaluation and management for people who may have an interest in traveling or climbing mountains and so on and so forth. What advice would you give to us in terms of looking for a physician or looking for someone who can give you appropriate advice to make your trip successful without any illnesses? Do you have any guidance on that for us?
You have to look for someone who has, who is part of ISTM, which is International Society of Travel Medicine, where you're focused, because it is a specialty. It's not just random things. I mean, there are studies done on it, and you want to get the best information you can get.
I'm sure there are people available. I mean, people from all over the world are traveling. If somebody were to reach out to travel medicine specialists, well, let's just say for yourself, for example, are those options available to people from different parts of the world?
Yeah,
opportunities for online consultations and so on and so forth?
See, the ISTM has members. They have like 2,000, 3,000 members all over the world. Like when we have these meetings, they come from everywhere. And usually the meetings are in, they have the meetings all over the world too.
Any information on malaria vaccine?
The efficacy is not that high, but that's all they have. So I don't think they've reached a point where you're going to see here. I mean, they're just using it in spots. They're doing more studies, I think.
Okay.
And it's a complicated parasite,
Yeah.
Malaria.
So this is another question. Your experience and your what you went through climbing up Kilimanjaro. How did you handle the toileting issues? I mean,
that was a big issue. The tents that we had, they had a porta potty, which is a little plastic toilet that you had.
Yeah.
And there was no flush. It was like a handle. You had to move stuff around. So it was complicated. Like you wanted to use it. You wanted to be the first one to use it. Let's put it that way.
Yeah. Yeah.
But some people had a hard time with that. So they were using Mother Nature. They were just going outside, which is another issue. So we went into situations where some people got constipated. They didn't want to go to the bathroom, but that's not a good thing.
Yeah.
So, we had some Colace, for instance, a stool softener, because people were getting into all these issues.
So I know you've spent a lot of time. I think there's one question and then we'll stop.
Sure, no problem.
And we appreciate it. Are airlines requiring any sort of evaluations before travelers travel to certain areas? Is there any requirement on part of airlines?
As long as you...
When you travel,
you pay for your ticket,
any piece of paper or anything before you?
See, I mean, like when we went to Kilimanjaro, I mean, the whole plane was, I think, full of hikers, but they didn't check anyone. I mean,
yeah,
like you have to walk onto the plane, which is a test if you can walk. And if you're walking around the plane, you find, they don't check. Otherwise, it would become,
right.
that would not be a practical way of thinking.
Yeah.
I mean, you
Yeah,
have to have it in yourself. You don't want to
Yeah.
die.
No,
You're going on a trip.
absolutely.
Right. You don't want.
Yeah. I think that would be probably a responsibility of the government and customs. So if there are certain vaccinations required when you enter the country, I'm thinking of yellow fever and so on and so forth, then it would not be the airline, I would imagine.
It's like the only required vaccines are usually yellow fever.
Yes.
When you go
Yeah.
to Saudi Arabia, you need a meningitis and a polio
Yes.
shot. So those are
Exactly.
the main things. That's
Yeah. Yeah. Okay.
Well,
this has been absolutely amazing, and our gratitude to you. Absolutely an amazing discussion. We love the pictures from Kilimanjaro, and we thank you, and we appreciate your time and your expertise on the subject.